Really for us, we will be studying.
All right?
Please.
Abdomen. So we start with superficial palpation. So often we put the hand on the abdomen of the child and simply see how he's reacting.
Your hand must be
We need some time to relax. The child needs some time to relax. Right? I'm not sure what the doctor is doing. He's some time to relax. So we simply relax, let it be there. Child relaxes. Then we start superficial palpation. Superficial palpation is conducted whether it's in a clockwise fashion or counterclockwise fashion. Doesn't really matter to me. I prefer clockwise. I know in therapy they prefer counterclockwise sometimes. Doesn't matter. You're simply checking to see for three things. One, hypertension. Hypertension of muscles. Right? If the muscles are very dense in a particular spot, this is called what? A deference, a resistance, a local muscular resistance. Okay. You're also looking for pain. If the patient starts saying, "Ow, that hurts," right? You're looking for pain.
No.
And three, you're looking for hernias. Hernias. You had surgery. You know what hernias are? That's what you're looking for. So any kind of muscular separation, right? Something's wrong anatomically. So that's all conducted with superficial palpation. If you find any zone that hurts, that means that's the zone you're going to be doing last or not doing at all for deep palpation. Right? The next type of palpation is deep. Deep palpation is meant to palpate the large intestine, the colon. Deep palpation always starts with the sigmoid colon. Is done bimanual. You place two hands, one to support from underneath, to support from. The second one is to palpate the actual intestine. You want to palpate it this way. You want to push the skin towards the center and slide your hand in. Push the skin towards the center and slide your hand in. Deep palpation. You're going to be feeling the colon, which means you're going to be feeling a cylindrical shape under your fingers. Normally, you'll have to describe what you're palpating. So the palpation is a cylindrical shape. Then you want to mention the diameter. The diameter shrinks as you go along. So this will be the smallest, about 1.5 centimeters, 1.5 centimeters in diameter. Here it's going to be the largest, about 3.5. So this is going to be about 2.5, 2.5, 2 centimeters, about 1.5 here for the sigmoid. Okay? So a cylindrical object, 1.5 centimeters in diameter, smooth, elastic, right? Painless, and usually slightly movable, right? And usually no sounds of digestion or peristalsis are heard in this region. If it's very dense, that would mean it's spasm. The region is spasmed, right? If it's very dense, usually painful, right? And the region is spasmed. If there's digestive sounds here, usually means that there's active peristalsis, probably diarrhea, because in the sigmoid there should be no digestive sounds. Right, so you're palpating the sigmoid. Then you're moving on to the cecum. Cecum palpation also this way. You're supporting from underneath and you're gliding it this way, side to side. Then you're going to colon ascendens, the ascending colon. Again, supporting from underneath, sliding the skin this way and palpating the colon, easily palpable right here. You're describing the shape. The transverse colon is slightly different because you're going to be feeling it not directly but through the rectus muscles and through the omentum. Feeling with two hands above the umbilical, about right here, right here. It's going to feel different. It's not going to be quite so cylindrical under your finger because you're feeling it through layers of muscles and the omentum. But you can still feel the shape, sort of. Right? You can still describe it. Then you're moving on to colon descendens on the other side. Same thing. Like this. So you're pushing everything towards the center to get the omentum towards the center, so you get direct palpation. Pushing towards the center. And pushing from the underneath also at the same time, so the intestine doesn't fall down. So you're supporting it like this, with your hand, from underneath. And then you can easily feel it right here. Okay? Deep palpation. And you're describing each segment. Next, Next, we need to find out where the edge of the liver is, liver size, and palpation of liver. So before we can find out the palpation of liver, we need to know where the liver edge is. The liver edge, we simply percuss down to find where the liver edge is. We are doing it along the medial clavicular line. We find the liver edge. Once we find the liver edge, we can do palpation. So if it's lower, we want to be palpating lower. If it's higher, right under the costal line, we're palpating higher. In order to palpate the liver edge, you'll have to ask the patient to breathe with the stomach. So you breathe with your stomach. Push your stomach out, push your stomach in. You put your hand in as the stomach is pushed in, breathe out, push out the hand. You're pushing out the hand, the diaphragm lowers, and the liver edge will fall onto your fingers. So one more time. Breathe in, breathe out. And you're sliding your fingers along the liver edge. The normal liver edge is sharp, mostly elastic, soft elastic, painless and smooth. No bumps on it, right? It's smooth. It's mostly elastic. It's not hard. It's soft elastic. It's sharp, right? And there's no pain. Then you want to be doing percussion of the liver sizes. Now, percussion of liver sizes, you want to find 3 liver sizes. This is called Kurlov's method of liver percussion. The first liver size you want to find along the medial clavicular line, the vertical size along the medial clavicular line. The second size is along the mediana line. And the third size is a skew size that's found along the left costal arch. It's conducted this way. First, you percuss down until you find the diaphragm, the upper edge of the liver. It's the same place that you were doing borders of the heart. You percuss down. You should already know where it is if you're doing the borders first. So you percuss down to find the upper border. Then at the same line, you percuss up from the abdomen to find the lower border. And now you have a size. Right? That'll be the first size. This is called point A. This is point B. Point C, you simply go along the horizontal line and you find point C. You don't percuss anything. Then you find point D by percussing up. You find point D. That's the second size. This was the first size, about maybe 10 centimeters or 12 centimeters. The second size, about 10 centimeters, 8 centimeters. Now you're finding the third size, this way. Finding the third size. Maybe about 7 centimeters or 8 or 6. 3 sizes. Kurlov's method of liver percussion. Okay?
The third one from which line?
Basically, you're going again to point C, which is right here.
C,
But you're making this kind of an askew line along the costal arch.
Okay.
Like this. And you're going from axillaris media towards the center to find this line. Okay. Next. Next, we're looking for the piloro-duodenal zone. We need to identify the piloro-duodenal zone. It's called the Schofard zone. The Schofard zone. The Schofard zone is located right here. This triangle is the Schofard zone. How do you find it? Basically, you're saying, okay, this is the umbilical and we're going to the axillary region. We're forming a line. This is the costal arch. We're taking this segment from the umbilical to the costal arch, and we need to take about 1/3. 1/3, look. See? 1/3 of this segment. This will be the edge of the Schofard zone. Now we're making a triangle. This is the piloro-duodenal zone. Palpation in this zone, if it's painful, it could mean almost anything. Usually it refers, of course, to the duodenum, but technically cholecystitis, pancreatitis can give us pain there. Even sometimes gastritis and even sometimes appendicitis can give us pain there. So palpation is not very specific in this zone. However, there's a percussive symptom called Mendel's sign. It's done like this, in this zone. If it's positive, this usually identifies either ulcer of the duodenum, acute duodenitis, or acute period of chronic duodenitis. But the Mendel symptom classically is checked in the Schofard zone, but you can also check it in other zones. So when you check, you go like this. Under the xiphoid, in the left epigastrium. So pain here signifies usually gastritis in its acute stage. Here, pain signifies usually a complication of gastroduodenitis called the duodenal gastral reflux. And pain here usually is for duodenitis or duodenal ulcers. Those are the three regions that you want to check. Okay?
Yes.
Just a reaction of patient will be feeling pain? Or?
Yeah. Yeah, he will feel pain. If there's something wrong, the patient will feel pain. Okay, Mendel sign. Next, we're going to be doing 6 signs for the gallbladder. 6 signs for the gallbladder. You need to know them all. 6 signs for the gallbladder. First one, Ortner's sign, conducted like this. Do you feel pain? No? If the answer is yes, then you need to point to the place where you feel pain, on the right or on the left. Don't ask the patient to say, do you feel pain here? Because the patient may just simply agree with you. So you want to always do comparison. If the patient says, yes, I feel pain here, then that means there's a problem with the gallbladder. This is done for comparison. Ortner sign. Yegorov sign. Yegorov sign.
You feel pain?
Nothing. This is very different. This one you hit with the edge of your hand. You're focusing, where do you hit? On the middle of the costal arch. Exactly in the middle.
Mm-hmm.
It has to be perpendicular. So the costal arch goes this way, you hit this way.
Mm-hmm.
You're focusing the middle of the costal arch right here. That's going to be the place of the gallbladder. Localization of the gallbladder. And you're comparing. If the patient says, I feel pain here, it's probably gastritis.
Mm-hmm.
Right? That's the stomach. It's 1, 2, or you can go 1, 2. You can hit once or twice. Just don't go like this. Don't do that. Same thing here. This is different because this, you're placing your hand. This is the costal arch. You want to be placing your hand completely on the liver itself. This is the liver.
Mm-hmm.
And you're checking this. What's the difference? Here, you're going for the gallbladder with this one. Here, you're going for the entire liver. So, for instance, if there's a dysfunction of the gallbladder, whether it's cholecystitis or a functional problem, and the bile is not coming out, it's going to be staying in the liver. You're going to get biliary stasis in the liver. The liver capsule is going to expand and stretch. It's going to be very sensitive. This method is very good for identifying biliary stasis, whether it's cholecystitis or non-cholecystitis biliary stasis. So, Ortner, Yegorov. Next, Musi. Musi is conducted this way. You place your fingers on the neck, above the clavicle, between the 2 legs of the sternocleidomastoidous muscles. On the neck, it's right here. See the legs of the muscle? The medial leg and the lateral leg. Right here. You want to place your fingers in between them, right here.
Mm-hmm.
And you press slightly. If the patient feels pain here, then it's a positive Musi sign.
You press here and you press here.
Because here is the place where nervus phrenicus goes. If there's a problem with the gallbladder, nervus phrenicus will be sensitive. It's a reflex sign. You press on the nervus phrenicus, the patient feels pain here. If he feels pain here, you're pressing too hard. Yes, no? Right here, that's the placement. Right above the clavicles, between the 2 legs. Musi sign. Musi sign. So, Ortner, Yegorov, Musi. Next, you want to find Kerr's point. Kerr's point is the point of projection of the gallbladder. There are different ways of finding it. I find the best one is to look at the lateral edge of musculus rectus abdominis. This is musculus rectus abdominis dexter, the right muscle. And eventually this muscle intersects with the costal arch, which is about right here. You want to move down 1.5 centimeters below the costal arch and press directly down. No pain. If the patient feels pain, it's a positive Kerr sign. Positive Kerr sign. That's what I just said. That's Kerr's point. Pain in Kerr's point is positive Kerr sign. Right here, that's Kerr's point. Another way of finding this again, going from the umbilical to the axillary, finding the intersection with the costal arch, and then going back about a centimeter. It's going to be about the same place. Approximately the same place. That's Kerr's point. Pressing down in Kerr's point, you're checking for Kerr's sign. If it's a positive sign for cholecystitis, gallbladder symptoms.
Oh, it's positive. You feel pain, yeah?
Yeah, pain. Yep. Next, if the patient feels pain, you don't check the next sign I'm going to show you. But if the patient does not feel pain, then you can check the next sign. It's called Murphy's sign. Murphy's sign. Murphy's sign is conducted when Kerr's point sign is negative, because Murphy's symptom is more sensitive. You're going to be doing it this way. You place your thumb in Kerr's point. Ask the patient to breathe with his stomach. Again, breathe with your stomach. You put the finger under the costal arch. Push out the finger. As the patient pushes out the finger, if the patient feels sharp pain, it's positive Murphy's symptom. Murphy's symptom is positive not when you press your finger inside, but when the patient pushes it out and feels pain. This is more sensitive. Murphy's symptom in general is uncomfortable, which means that when you put your finger in, the patient may feel discomfort. That does not count as positive Murphy's sign. All right? Murphy's symptom. And last is Lapine symptom. It's percussion in Kerr's point, like this.
Sorry? Lapine?
Lapine.
It's French, yeah?
Yeah, lapine.
Percussion in Kerr's point. So there's 6 of them. Ortner, Yegorov, Musi, Kerr's sign, Murphy, Lapine.
For cholecystitis.
Cholecystitis, functional disorders, these are all vesicular symptoms. Vesicular signs. 6. Now pancreatitis, 4. 4. Easy. The first one is the sign of the pain in the head of the pancreas. The pancreas is localized like this. Pancreas is somewhere around here. Pain in the head of the pancreas. Now the head of the pancreas is easy to find because you've already found it. It's the edge of the Schofard zone. Remember the Schofard zone? This line, 1/3. This is the Schofard zone. Well, this angle of the 1/3 of the Schofard zone is called Desjardins point. Desjardins point. Desjardins point. The head of the pancreas. A mirror reflection, or almost mirror reflection of it, on the other side, except that instead of going 1/3, you go 2/3, is the tail of the pancreas. Look. Head of the pancreas, not exactly reflection, but sort of kind of weird mirror reflection. 2/3 from the umbilical is the tail of the pancreas. This is called Mayo-Robson's point. So, Desjardins point, Mayo-Robson's point. Now you can check them like this with one finger, Mayo-Robson's point, the Desjardins point, Mayo-Robson's point. I prefer to put 2 fingers at the same time. This way you can check the symmetry. If you're putting them like this, you're wrong. It's like this. See, asymmetrical. And you press 1. Painful.
Oh,
You relax, relax, relax.
In my what? My operation.
Scar? Yeah, there's some scar tissue. Inside there's some fibrin.
Maybe.
Tail of the pancreas. Okay? Desjardins point, Mayo-Robson's point. Those are the 2 points and the symptoms. Pain symptom in these 2 points. Now we have 2 more symptoms. One is for acute pancreatitis. Acute pancreatitis symptom is, first symptom, it's called Kerte sign. Kerte sign. Not to be confused with Kerr's point. Kerte sign. Kerte sign. It's diffuse and pain during palpation of the pancreas. So, this is the pancreas. You place your fingers on the pancreas, and the muscles are tense. You can't do anything. You're not letting, the patient says, ow, that hurts a lot. So, pain and diffuse during palpation of the pancreas is called positive Kerte sign. This is a sign of acute pancreatitis. We have a sign of chronic pancreatitis. Chronic pancreatitis is characterized by the Kacha sign. Kacha sign. Kacha sign says there is hyperesthesia of the skin above the pancreas if there's chronic pancreatitis. The more specific region of the skin that is hypersensitive is the skin region that is innervated by the 8th vertebral segment. The zone of innervation of the left 8th vertebral segment. So it's to the left. What you're doing for the sign is you're checking sensitivity of skin by simply going like this. If the patient feels discomfort or pain, so it can be, oh, I don't like it when you do that. Or, well, you're just going like this, gently going on the skin. If the patient feels severe discomfort, like, oh, I really don't like it when you do that, or he actually goes, ow, that hurts, that's positive Kacha sign. The skin is so sensitive in this region that the patient may experience pain. It's sensitive because there is local peritoneal excitation. So there's local peritonitis. Okay? So, Desjardins, Mayo Robson's, Kerte, and Kacha.
Kacha?
Ortner, Yegorov.
I like Kacha.
Musset, Kerspoint, Murphy, Lapine, Desjardins, Mayo Robson, Kerte, Kacha. Chauffard zone, Mendel sign. Okay?
Okay.
Appendicitis. Legs. Straight. Now, appendicitis is diagnosed when we're palpating the Mac-Burnet region. It's located here, between the some kind of frontal iliac spine and the pubis. Right here, Mac-Burnet zone, or Mac-Burnet region of palpation. The patient experiences pain in the Mac-Burnet region during palpation. It's a positive sign of appendicitis. Pain and defunds in the Mac-Burnet region. Just like this was acute cholecystitis, we had pain and defunds. For the Kerte sign, we get the Mac-Burnet sign in the pain and defunds in the Mac-Burnet zone. That's one. 2, Sitkovsky sign. You keep your hand in the Mac-Burnet zone, and you lift the patient's straight leg up, straight. You're lifting it up. As you do, the patient says, ow, 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 doctor, that hurts more. If the pain increases in the Mac-Burnet region, as you lift the straight leg up, this is positive Rovsing sign. Positive Rovsing sign of appendicitis. Next is, we also have, if this happens, there will be local peritonitis, which means we'll have hypersensitivity of skin. Hypersensitivity of skin. This is also checked by the Voskresensky sign, usually done either on the skin this way, from the costal arch down, or using a shirt, like this one, a thin shirt, and you slide your fingers down from the costal arch down to the Mac-Burnet region. The patient will experience pain if he has appendicitis or any kind of peritonitis on this side, for any reason. This is a peritoneal sign. It's not really specific for appendicitis, but in children, it's often associated with appendicitis because that's the most common cause of appendicitis, of peritonitis in children, appendicitis. But it could be other things. Cholecystitis can give us positive Voskresensky sign as well. If it's acute, if there's peritoneal changes. Next, we can ask the patient to lie on his left side. Please lie on your left side. Just turn and lie on your left side. As the patient, we're almost done, about 1 more minute.
1 minute, yeah. Just one more time.
It's 25 minutes. Quickly, go.
Quickly, Rebecca.
So, as the patient turns from his back to his side, he says, ow, my pain in the Mac-Burnet region just got more severe. Right? So as the patient turns from his back to the side in bed, he says the pain in the Magburnet zone increased. This is positive Sitkovsky sign.
Just that?
Positive Sitkovsky sign. Yep. Increase of pain as the patient turns to the side, to lie on the side.
You get a name for that?
Yep. Also, if you're palpating the Magburnet zone, and you again ask the patient to turn to the side, and the patient says, when I'm lying on my side and you're palpating here, it hurts more as compared to when I was lying on the back. That's a different sign. That's called the Bartholomew-Michelson sign.
You get a name, so...
Bartholomew-Michelson sign. Bartholomew-Michelson sign. Yep.
That's all.
Bartholomew-Michelson sign.
So we
Lay
don't.
down. Lay down.
One more symptom.
One more.
And this one you should know from surgery. This is the Shotkin-Blumberg sign.
Yeah.
Shotkin-Blumberg sign. This is a sign of peritonitis or acute abdominal sign. If the patient exhibits pain here during superficial palpation, that may mean that this is appendicitis. Right? Which means that typically, unless it's a very small child, he will have localized peritonitis in this area. Which means that the Shotkin-Blumberg sign will be positive here. However, if the patient has, for instance, phlegmonous cholecystitis, and therefore develops peritonitis, this is the region of the peritoneum that's going to be most inflamed. He's going to get positive Shotkin-Blumberg sign here. Perforative ulcer of the stomach here. Ulcerative colitis here. Plus other pathologies in other different places. This is just as an example. Which means that Shotkin-Blumberg sign can be checked in different places, not just one place. This is a sign of peritonitis. It's a sign that the inflammation got really bad. It's not a sign of an actual appendicitis. It's not a sign of appendicitis. This is a sign of appendicitis. This is not. It's a sign of peritonitis. There can be various reasons for peritonitis. Right? More reasons for girls for peritonitis, because we can have ovarian inflammations that can give us also peritoneal signs. Okay? Even pregnancy, ectopic pregnancy especially, can give us same symptoms similar to appendicitis with peritonitis. Shotkin-Blumberg is checked this way. You slowly press, quickly let go. 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 As the abdominal wall bounces upwards, the peritoneal leaves fluctuate, which causes severe pain if there's peritonitis. The patient will go, ah! He will scream because it really hurts. If you want to diagnose appendicitis, what you do is you do Magburnet, you do Rovsing sign, you do Sitkovsky sign, you do Voskresensky sign, then you do the Shotkin-Blumberg sign. Because plus, if you think it's appendicitis, you want to go like this. Check here, check here, check here, and then check here. For small children, they're going to have always diffuse peritonitis, which doesn't matter where you're checking, it's going to be positive. If you check, for instance, if patient says, okay, it hurts, my stomach hurts, and you go, okay, let's check Shotkin-Blumberg, check Shotkin-Blumberg, it's positive, and you say, oh, maybe that's appendicitis, let's check Rovsing sign. Too late, it's going to be positive anyway.
Oh, why?
Because after this, it's going to be painful for at least another 15 minutes. Which means anything else you check is going to be positive. Doesn't matter what you're checking. You've just spoiled everything. You'll have to wait for 15 minutes for the patient to recover before we can start again. So that's the last thing you want to check.
So, what is the...
Unless you're a worker of the ambulance and you don't actually care what the diagnosis is, you care only to find, does the patient have acute abdominal sign? Do I take him to surgery? Or not? In which case, if you're working on ambulance, you can just come in and go, Shotkin-Blumberg positive, you have acute abdomen, I don't care what you have, appendicitis, peritonitis, salpingitis, it doesn't matter, I'm taking you to surgery, I don't really care.
Yeah.
The surgeons will diagnose you 15 minutes later once you arrive. Right? So, that's possible. But if you really want to make a diagnosis, you won't do that. So, superficial palpation, deep palpation, sigmoid, cecum ascending, transversus descending. Edge of the liver, palpation of the liver with the abdominal breathing. Kurlov's percussion of the liver. Right? Kurlov's percussion of the liver. Finding the Schofard zone. Finding the Schofard zone. Percussion Mendel sign. Ortner sign. Yegorov sign. Musi sign. Ker's point. Murphy sign with abdominal breathing. Lapine sign. Desjardins point. Mayer-Robson's point. Kerte sign. Kacha sign. Magburnet region. Rovsing sign. Voskresensky sign. Sitkovsky sign. Baltimore-Michelson sign. And Shotkin-Bloomberg sign.
So should we...
You need to know them all.
Okay.
Thank you.
Teacher, all this, it should be like